Acute respiratory failure is a common reason for intensive care unit admission and often requires positive pressure ventilation. It is a life-threatening condition where oxygenation becomes the first priority following airway, breathing, and circulation principles. It is defined as the inability of the respiratory system to meet oxygenation, ventilation, or metabolic demands. The respiratory system includes lungs, airway, chest wall, cardiovascular system, and neurologic control. Type 1 respiratory failure is defined by arterial oxygen partial pressure less than 60 millimeters of mercury. Type 2 respiratory failure is defined by arterial carbon dioxide partial pressure above 50 millimeters of mercury with pH less than 730. Arterial blood gas, chest X-ray, computed tomography, and bronchoscopy are key diagnostic tools. Hypoxemic respiratory failure threatens vital organs due to inadequate oxygen delivery. Supplemental oxygen is the first-line therapy to correct hypoxemia. The most common mechanism is ventilation-perfusion mismatch, which improves with oxygen therapy. Shunt occurs when blood bypasses ventilated alveoli, resulting in ventilation-perfusion ratio equal to 0. Shunt is resistant to oxygen therapy and often requires positive pressure ventilation. Dead space ventilation occurs when alveoli are ventilated but not perfused, leading to ventilation-perfusion ratio approaching infinity. Early signs include tachypnea and labored breathing with initially normal carbon dioxide levels. Hypoxemia refers to low arterial oxygen, while hypoxia refers to impaired tissue oxygen utilization. Oxygen delivery depends mainly on cardiac output, hemoglobin, and oxygen saturation rather than arterial oxygen alone. Hypercarbic respiratory failure results from inability to eliminate carbon dioxide. The control of carbon dioxide begins in the medulla and travels through the phrenic nerve to the diaphragm. Causes can be localized from brainstem to lungs, including neuromuscular and structural abnormalities. Brainstem causes include drug overdose, hemorrhage, infection, and metabolic encephalopathy. Spinal cord lesions above cervical level 4 can impair diaphragmatic function. Peripheral nerve disorders such as Guillain-Barré syndrome can cause respiratory muscle weakness. Neuromuscular junction disorders like myasthenia gravis impair signal transmission to muscles. Muscle disorders and electrolyte disturbances can directly impair ventilation. Thoracic cage abnormalities such as kyphoscoliosis or obesity restrict lung expansion. Pulmonary causes include chronic obstructive pulmonary disease and dynamic hyperinflation. Metabolic states such as sepsis, trauma, or thyroid storm can increase carbon dioxide production beyond elimination. In severe metabolic acidosis, ventilation must increase significantly to maintain normal pH. Upper airway obstruction presents with stridor and requires early airway intervention. Treatment focuses on reversing the underlying cause and supporting gas exchange. Supportive therapy includes oxygen, bronchodilators, and non-invasive ventilation such as continuous or bilevel positive airway pressure. Invasive ventilation is required in severe cases such as acute respiratory distress syndrome or neuromuscular failure. Mechanical ventilation is supportive and aims to maintain gas exchange until recovery. Oxygen delivery devices vary from nasal cannula to high-flow systems delivering up to 100% fraction of inspired oxygen. High-flow nasal cannula can deliver up to 60 liters per minute with precise oxygen control. Weaning from ventilation occurs once the patient can maintain adequate oxygenation and ventilation independently. Early recognition, rapid oxygenation, and targeted treatment of reversible causes are the key principles of managing acute respiratory failure.